Yeah, I think morphological assessment has been the backbone of diagnostics in patients with MDS, but I think morphology, of course, has sometimes also inter-observer variability, also counting blasts, as we know, has some challenges. Sometimes it depends a lot on the experience of the heme pathologist. But I think still it is the backbone. It is what we do to get a first impression on whether the patient may have an MDS, but also it's maybe prognostic given the number of blast cells, which actually define also the individual prognosis of a patient. On the other side, the recent updates on the classification, like WHO classification, have now implemented two new categories, the so-called MDS SF3B1 and the MDS with B allelic P53 inactivation, which I think is a clear indicator that molecular abnormalities should be an integral part of the workup of an MDS patient. But I think the challenge, as I also mentioned in my previous answer, is the availability and the access to these molecular testing. Sometimes it's also reimbursement coverage by insurances. And I think this is still a challenge many of our colleagues are facing. But I think with the time being, this will be resolved and will be an integral part of the workup of MDS patients.